Hello, I'm Dr. Jeffrey Niezgoda, and welcome to the first Kent webinar. We'll be talking about some really interesting technology today. We're going to have some fun in this webinar. We are going to actually go into the clinic and give you an experience with how we use this technology on patients, and we'll have some time to interact at the end, Q&A. So I'm really excited about this webinar and this educational opportunity that Kent has provided all of us. So thank you very much to the kind folks at Kent Imaging. So let's talk about near-infrared spectroscopy. What is it? What does it mean to us as wound care clinicians? Let's talk a little bit about near-infrared technology. There is really only one of these technologies on the market today, so it is a very niche type product. However, near-infrared technologies are based on taking light at a certain spectrum of the electromagnetic focus and using that and interpreting that. This technology is not new. It might be new to wound care, it might be new to vascular medicine, but it is not new to the world. This technology, near-infrared technology, has been developed and has been used since the 1970s. However, most of the applications of near-infrared spectroscopy has been used in industrial applications to this point. Due to the recent advances in technology and the ability to downsize the devices, we are now bringing this technology into the medical world. So it's important to know that this technology focuses on the near-infrared spectrum, which lives between 600 and 1,000 nanometers on the electromagnetic spectrum. We'll explain that in a little bit more detail. So again, near-infrared spectroscopy is an imaging technology that is based on the principle that light is absorbed and reflected differently for both oxygenated and deoxygenated or non-oxygenated hemoglobin. And this cartoon here shows the electromagnetic spectrum, near-infrared being kind of right in the middle, and you can see the wavelengths that are reflected by the use of this technology. So let's take a look actually how this technology is used clinically. Again, it's very small, portable, can easily dovetail into your clinical practice. We see a patient that is being imaged with near-infrared spectroscopy. The device is held, the image is focused, and then with a click of the button, these images are produced. Again, the analysis happening of these different wavelength spectrums inside the camera producing these images. Now we're going to go into the clinic a little later in this webinar, and you're going to actually see this demonstrated in more detail in a variety of different clinical settings, and you can see how the device actually works, but we'll save that for the end. Once you have an image, you're actually able to go into the screen, into the device, and touch anywhere on the image to actually obtain a value, a sampling value of a comparison of oxygenated to deoxygenated hemoglobin. This is a saturation value, and we've been using these for a variety of applications in the clinical setting. I'm going to walk you through those in this presentation. But anyhow, this is, the pictures are pretty, right? But really, when we're able to get an actual value of an area of interest in a patient's wound or extremity, that's where the value really comes to us clinically. So when we get that value, we need to interpret it. And there's a lot of things that do affect oxygen saturation, hemoglobin saturation. For example, when we have low oxygen saturation, that can be reflected from decreased oxygen supply, a decrease in local perfusion, potentially patients with decreased cardiac output, anemia, different forms of hypoxemia. All that can lower oxygen saturations. Alternatively, if you have a tissue that has high metabolic demands, and so it's really consuming oxygen, and you have increased extraction of oxygen from the blood, certainly that can depress the amount of oxygen that's saturating the hemoglobin. We see this sometimes in inflammatory states or in infectious states, but again, when that consumption of oxygen exceeds the baseline, we'll see a depressed oxygen saturation. Alternatively, high oxygen saturation imaging, if we have increased FiO2 that is being inhaled or taken in by the patient in certain settings, whether they're having, for example, hyperbaric therapy or they're intubated on 100% oxygen for therapeutic reasons, if they've just undergone a revascularization, we have more blood flow, obviously bringing more oxygen. you're going to get a higher oxygen saturation. An alternative to the tissues that are using oxygen at a high metabolic rate and high consumption, if those tissues are not utilizing oxygen, that could reflect an increased oxygen saturation in the imaging. And then there are certain states of mitochondrial dysfunction when there is an inability to utilize and consume the oxygen. Again, you'll see those elevated levels. And so it's important to understand that there are a lot of factors that come to play. And although the photos are very pretty and dynamic and we can get spot checks of the saturation in the tissue, we need to do a little analysis of those images to understand the clinical situation and the dynamics of the patient that may reflect what those numbers actually are. So let's look at the utilization of near-infrared spectroscopy, evaluating tissues as a response to therapeutic indications, because this is really what it's all about. A patient comes in and certainly you can get a baseline image and sort of get a sense of how well oxygenated the tissue is at any time. However, what we really want to know from a clinical standpoint is, especially in those patients that have low oxygen saturations, we know that low oxygen tensions in tissues certainly can have a negative impact on the ability to heal. So therefore, we want to see those numbers elevated. And if they do come in depressed, what can we do about it? How can we influence those numbers? Can we increase oxygen saturation, reflecting increased oxygen or tissue perfusion, to analyze whether or not the therapy that we're actually delivering to that patient is making a difference. So let's look at a few of these. So what are some of the clinical applications that we have found helpful in using near-infrared spectroscopy in our clinic at AZH? Well, revascularization. We have not only a wound care clinic, but we have a vascular center. We bring these patients in, we evaluate them, we interrogate their vascular system, and then we intervene. My partner, Dr. Awais Siddiqui, is an interventional radiologist. He is a wizard with wires, I like to refer to him as, and he is very good at increasing tissue perfusion by going into these arteries and opening up areas of stenosis or occlusion, putting a stent in to revascularize. We have also had uses for this device on the venous side, looking at opening up legs with venous congestion when we have pelvic obstruction or obstruction of the venous system, and allowing improved outflow from the extremity. We've seen some reflectance of improvement of tissue oxygen saturation on the venous side as well. For the wound care, we've got a lot of experience looking at how near-infrared spectroscopy is utilized to guide our clinical decision, and to guide our decisions is whether our interventions are actually making a difference. And I'm going to share all of these examples with you. The bottom line is that we're able to use this technology on a serial go-forward basis and measure these patients day 1, day 7, day 14 to actually see changes over time with these therapeutic interventions. Been incredibly helpful in guiding our clinical decision making. We have studied using near-infrared spectroscopy in our endovascular clinic, and we've actually started to publish on this. And again, I think that this is going to be a technology that will guide endovascular surgical revascularization, endovascular specialists in their revascularization attempts, and determine how successful they actually have been. So here's a case that'll show you very briefly how we use this clinically to guide our decision making from an endovascular standpoint. This is a patient who was referred to us for gangrenous changes of the third toe, as you see here. We had set the patient up to receive an angiogram and what we suspected would probably be intervention. That patient didn't show up for about 3 weeks, was hospitalized due to infection, and we all know that these patients are at high risk for developing infections. Anyhow, he developed some progressive gangrene and underwent an amputation of that digit. When he returned to our clinic a few weeks later, this is the presentation. And what you'll see is that that digit amputation site has become gangrenous, compromised, and this patient clearly is at risk for progressive amputation and loss of his forefoot. We suspected that this patient needed revascularization. Unfortunately, the amputation was done under emergent situations, and little attention was paid to the revascularization. So we did some imaging, and we found that, in fact, the patient really did have some significant deficits from a near-infrared spectroscopy standpoint, and this complemented what we found in the endovascular lab. The patient required extensive work on his SFA and distal vessels. He was treated with angioplasty and stenting, and then we were able to follow him after the revascularization. And what was very interesting on a go-forward basis is that the improvement in the near-infrared spectroscopy imaging reflected what we saw clinically. This patient did go on to heal and did not end up losing any more of his extremity, did not require transmetatarsal amputation, and we followed these images serially to guide our decision making. So this is how we use these images to complement what we do on an endovascular basis. I mentioned in the wound care clinic we use it extensively to evaluate the success or failures of our interventions, and I suggested to you that we use it pre and post debridement quite frequently. I'm a big fan of ultrasonic debridement. Here you see the Arabella device in use. This is a great technology. If you're not familiar with it, I would certainly suggest that you take a look at it. It does a great job of treating the wound from a debridement standpoint, but it also has the effect of cavitation, which decreases bacterial load across the wound base. Here is a pre and a post debridement image. Now, looking at these images clinically, you'd say, yeah, we did a nice job of debriding that wound. It certainly looks a lot healthier. It's much more granular. I'm happy with that. But that's all we had up to this point. Have we made an impact on this patient from an oxygenation, from a perfusion standpoint? Well, when you add near-infrared spectroscopy to your standard clinical digital imaging, you can see what we are seeing in our clinic. You'll see in the top right image, obviously that is reflective of a pre-debridement Kent image, and then you see the post image supports and reflects what we see post-debridement, that wound is much more well perfused and oxygenated. And when you, again, use the touchscreen features, you can actually measure and quantitate the increase in oxygenation and tissue perfusion following that debridement. Shockwave is another therapy that we utilize fairly frequently, probably on a day-to-day basis in our clinic. This is a technology that, again, delivers acoustic shockwaves to the tissues, has a multiple number of impacts on the tissue and positive outcomes. There's some cavitation that goes on. We know these stimulate and downregulate the inflammatory response in the tissue, so it has a number of helpful mechanisms for wound healing, and that's why we have incorporated it into our practice. Here are some images pre and post shockwave. Now, what's interesting about these images, in a difference to the debridement, you look at the digital image with the debridement and say, yeah, I've done a nice job. Here, you look at the images and you go, I don't see a lot of difference here. This is a patient actually with Raynaud's disease, and she came in with very significant pain, especially in her great toe. And post-shockwave treatment, again, digitally, you don't see that much difference. However, when we take and we incorporate near-infrared spectroscopy, look at the enhanced tissue oxygenation seen in that digit. What was real interesting about this case is that not only did the patient measure out from a saturation standpoint of having a good response to the shockwave, she actually came in the next day with out-of-schedule visit, asking for another treatment, saying that her pain was so much better that she wanted another shockwave treatment. And again, I think this is totally reflective on the fact that we've increased tissue perfusion with shockwave, and we can actually demonstrate it here with near-infrared spectroscopy. Hyperbaric is another modality that we use in our clinic on a daily basis, and again, we monitor our patients. I think this is going to be one of the big value-added areas for near-infrared spectroscopy. We all know that the therapeutic value of hyperbaric is cumulative. Rarely do you see marked changes day to day. Typically, it's over a period of time. And it's all visual. and it's all, you know, from experience. The patient's doing a little better, I think it's better, I think it's better. Can we actually demonstrate that with near-infrared spectroscopy, and can that help us to guide us on a go-forward basis? Here's a case pre and post hyperbaric, and again, I would challenge you to tell me that that digit looks much better following the hyperbaric treatment. Again, intuitively, we know that we've oxygenated the tissue, but again, when visual examination does not support the fact that we've really made a difference here. What happens when we add near-infrared spectroscopy? Look at how those tissues light up, not only in the involved digit, which obviously is the critical digit, but throughout the entire hand. We are getting additional oxygen to that tissue, and this imaging supports what we're doing. If you look at the tip of that finger, that's really where the value comes in here. As you can see how much more oxygen is in that tissue. That oxygen substrate is driving the healing, reversing the inflammatory change, reversing the ischemia reperfusion that is occurring in that tissue. And here we actually can see demonstrable evidence that post-hyperbaric, we have made an impact on that patient. And again, using the saturation values, we can actually measure the increases in those tissue areas of concern. Here's a case, very interesting case, looking at the margin of frostbite with hyperbaric. Real short application of hyperbaric therapy, an excellent outcome. Unfortunately, here in the northern tier of Milwaukee, we do see a fair amount of frostbite. I've had very good success with hyperbaric in managing these patients, again, from an acute ischemic standpoint. So this is a patient developed frostbite in the ends of the middle and ring finger. You can see the dusky changes illustrated here. And this was, again, a pre-hyperbaric photograph. We did image with near-infrared spectroscopy, and the correlation here is excellent. You can see in both of these digits, the oxygenation saturation values are much lower than in the rest of the digit. Post-hyperbaric, if you look at those fingertips, again, not seeing much improvement here. Is hyperbaric helping? Have we oxygenated these tissues? Does the patient have a good expectation of a good outcome from an oxygenation standpoint? Well, combined that with near-infrared spectroscopy, and you can see that, in fact, yes, we are making a difference. Those distal tips light up, and they are very highly oxygenated. Again, that is the goal of hyperbaric treatment, as you're all aware, and this shows that we have been successful here. Again, pre-hyperbaric, looking at the volar aspect of the hand, you can see those dusky changes. Pre-hyperbaric, the near-infrared spectroscopy does show significant deficits in those regions. Post-hyperbaric, now here I would grant you we do see some improvement visually, but when we combine that with near-infrared spectroscopy, beautiful improvement. This patient had just an incredible positive outcome to hyperbaric, no tissue loss. We use a lot of transdermal oxygen in our clinic, and as you all are aware, transdermal oxygen, topical oxygen is becoming a hot button item in wound care. This is a device that we use fairly commonly. It's called OxyBand, and it is an oxygen reservoir. Again, the only dressing of its type out there with an oxygen reservoir that delivers sustained oxygen over a period of time. The question comes up is when we put a dressing or a therapy like this, an oxygenating dressing on the wound, does it have an impact on that tissues? Does it actually raise the oxygen saturation of the tissues? Big question. Very difficult to determine just with the naked eye and visual analysis. But when we incorporate near-infrared spectroscopy in our clinical decision-making, you'll see these images. The one on your left shows pre-oxyband, pre-topical oxygen, and we do have some significant deficits in the wound, in the peri-wound tissue. Post-topical oxygen, this is after 48 hours of oxygenation, you can see that we've done a nice job of increasing the oxygen saturation in those tissues. This patient went on to develop very nice outcomes following the transdermal oxygen. Near-infrared spectroscopy and transcutaneous oximetry, I told you I was going to share some insights related to TCOMs. And I will be honest with you, other than looking at some research patients, we haven't taken our TCOM unit out of storage for clinical application in nearly 2 years. It has really become an outdated modality, a dinosaur technology that really did have significant value to us 20 years ago. I'm telling you now, this is a therapy that we're not going to talk about very much. And what have we found? Well, we did an analysis looking at the comparison of near-infrared spectroscopy to the values that were obtained with our transcutaneous oximetry device. And we found incredibly strong correlation between the values that we obtained from our TCOM device compared with the saturation values that we're obtaining with near-infrared spectroscopy. You can see the data there on the screen. Very, very close correlation. So what we're finding is that these can be substituted. We know that transcutaneous oximetry takes a long time. And here you see a comparison of one of our research images where you see that the TCOM averaged 69, where you looked at near-infrared spectroscopy. This is on site A. The near-infrared spectroscopy values averaging 64, again, very high, highly and closely correlated. The TCOM B electrode there, the TCOM value of 52, near-infrared spectroscopy average saturation 56, again, very, very close. I certainly think interchangeable here. Why do we like near-infrared spectroscopy versus transcutaneous oximetry? Well, transcutaneous oximetry exam, as you know, easily takes 45 minutes to accomplish if done correctly. There's a huge disposable expense with this. It really ties up the clinic for an exceptional period of time, and there are a lot of drawbacks using transcutaneous oximetry. Patients with edema, if you have an area that you can't get the electrodes close to, how do you determine what the saturation actually is in the wound base? You're sort of doing an extrapolation saying, well, on the proximal foot it's this, on the distal foot we expect it's probably worse. Here with near-infrared spectroscopy, we can actually look at the entire wound at the foot, and we eliminate a lot of those drawbacks that we have encountered through the years with transcutaneous oximetry. We're not the only group finding a positive value in using near-infrared spectroscopy as a substitute for transcutaneous oximetry. The Serena group has done a lot of work. Tom has published his findings, and I referenced this journal article, again, showing very strong correlation between the values obtained through near-infrared spectroscopy versus what we historically have seen with transcutaneous oximetry. So how do we use this technology? Well, we use it for clinical surveillance. I think that's the best way to sum it up. I can get some immediate feedback on tissue response, whether it's an immediate feedback on a response to hyperbaric or debridement or some intervention. I can look at that tissue immediately. And I can use it with a single intervention or with multiple combined interventions. For example, hyperbaric and shockwave and debridement. All on one day we see serial improvements in all those interventions. I also think this is a great device for doing prospective monitoring. So we can monitor these patients on a weekly basis and actually see gradual improvements in the tissue saturation over time. Very helpful. But I think the holy grail here is to do some prognostic imaging. Get an image on day one, and we can hopefully at some point be able to use those values to predict outcomes for healing over time. We're actually working with some researchers, some brilliant minds at the University of Wisconsin, Milwaukee, looking at artificial intelligence and the analysis of these images, as well as the saturation values that are being generated to see if we can do some prognostic assessments and make some prognostic declarations based on the deep learning neural networks that we're incorporating these values into. So I'm going to close this webinar with just a couple clinical examples and sort of how we use the technology. Here you see a pre-intervention image, near-infrared spectroscopy, again, intense values of blue and green. Again, those are low oxygen saturations. Compared to what we see in the image following intervention, here this patient received an endovascular intervention, a dermaPACE and hyperbaric. You see the improvement that we've noticed just in 1 week. This patient went on to do well, and we use this comparison of image to suggest that in fact our interventions were being successful. The last case I'd like to share with you is one of critical limb ischemia. You are familiar with that term, and it presents probably nearly on a daily basis to us in our wound care clinics. How we intervene and how we manage these patients certainly will predict outcome regarding limb salvage. We published this case in a journal, Wound Clinic, several months ago, and it was to walk us through a case example where we had a patient that underwent a podiatric procedure. The image that you see on the screen shows that she's had multiple interventions on digits 2, 3, and 4. She had pins placed, but the digit of concern is that third digit. You'll see the tip is necrotic. She came to us 3 or 4 days post-op with these changes. The podiatrist was very concerned that this patient was going to actually lose her limb or require a higher amputation. And we did some Kent imaging and saw that the tissues were incredibly desaturated, oxygen starved, and we went to work. So she was a non-smoker, non-diabetic, really was a fairly young lady, and really had no reason for this type of compromise. But when we did her imaging, we became very concerned about this being a vascular issue, especially with digit 3. And she did present from a concern of it being an embolic phenomenon. We found that she had a tourniquet used during the procedure, and that tourniquet time exceeded 2 hours. Again, you can see it was a fairly involved surgery. And based on our concern for it being an embolic event, I did involve my colleague, Dr. Siddiqui, and he agreed, and she underwent an emergent angiography the day we saw her. So here you see the pre-endovascular image, and that showed that she had significant compromise, especially along that D3 and along the incisions. She did undergo revascularization, and you can see the amount of work that was required. This was, in fact, an embolic event. Dr. Siddiqui was able to cannulize the dorsal pedis arch that we really thought was due to a distal embolization likely caused by the surgical tourniquet. These are some images from the angiogram that you'll see the digital arteries are impaired, and we have a discontinuity of the pedal arch. There was an angioplasty performed of the anterior tibial artery, and that allowed recannulization of the pedal arch. And here you see that she did have restoration and continuous flow of the anterior tibial artery into the pedal arch. We then did some imaging based on our interventions, and we went to work from a hyperbaric standpoint as well as an aggressive wound care standpoint. We wanted to share with you the near-infrared spectroscopy that sort of guided the outcomes here. This is pre-angiogram, pre-vascular intervention. Again, you saw this image before. Fairly concerning imaging based on oxygen saturation. Those digits clearly are at risk. But what I would like to share with you is look at her entire foot. There's something going on there. Blood flow is an issue, not only for the surgical sites, but for the entire foot. Again, this suggested that she did have an embolic event. Following her intervention and recannulization of the distal foot, we did re-image her, and now you'll see marked improvement of the foot. We still have compromise of those involved digits, but now we know we have blood flow and saturation of the foot following the revascularization effort. Here we see a post-hyperbaric, so patient underwent intervention from a vascular standpoint. We then put her in the hyperbaric chamber and then re-imaged her following that. And again, if you see and compare this image, this is impressive. We're oxygenating not only the foot, but look at the improvement in the oxygenation of the digits. Now, we use these images on a go-forward basis. She did have some ischemia over the tip of that third toe. She really did not want to have that toe amputated. And the near-infrared spectroscopy correlated pretty well that the necrotic tissue was just the dermis, just the skin, and that it suggested the rest of the digit was fine. We continued to monitor her clinically, and the near-infrared spectroscopy, again, suggested that that digit was salvageable, and she was going to do well. And in fact, after 22 hyperbaric sessions, and again, the revascularization that we talked about earlier, we were able to monitor her over time. Here you see her images about 2 months into this whole process. Again, that tip of the toe looks bad. We talked about taking the toe and doing an amputation. She did not want that at all. And I was comfortable continuing to watch her based on the near-infrared spectroscopy. If all I had were these digital images and what I could see with my naked eye, I probably would not have gone forward with the salvage attempt. We probably would have strongly pushed her towards an amputation. So 2 months later, she came back, and lo and behold, digit 3 had completely healed. We salvaged the whole digit. This showed that what we imaged with our near-infrared spectroscopy camera predicted that that tissue was viable and that tissue had a potential of healing. There you see the digit has completely recovered. That cap, that necrotic cap that we're so concerned about, it showed excellent tissue perfusion under of that cap, and the rest of the digit was well perfused with excellent saturation values. So we gave her time. The tissue demarcated, declared itself, and she in fact healed the entire toe. She's exceptionally happy with this outcome, and certainly we are as well. So I think near-infrared spectroscopy brings a number of advantages to us clinically. Just a few of them. Decreased assessment time. I told you that this is just a single snapshot. You saw it in the video earlier, and you'll see it when we go to the clinic. It's quick, it's fast, and as opposed to some of the other tests of perfusion, transcutaneous oximetry, skin perfusion pressure, arterial Dopplers, ABIs, all of those take time. This is very quick, and it provides immediate assessment. There are no disposable costs associated with the device, which makes it financially a real plus. And it's non-invasive and really less burdensome. So everything else that we do, again, you do have to use the electrodes and the blood pressure cuffs and everything else. Here it's just taking a picture. I think the strongest advantage here is the bedside or in situ utilization that I've talked to you about. We can get an immediate image. We can follow that patient in a prospective fashion on a week-by-week basis, and I think it lends itself to just great prognosis, and hopefully we'll be able to use that through some of our artificial intelligence mechanisms with our wound database over time and bring additional value to you. So I'd like to thank you for your time and attention, and I hope you've enjoyed this didactic part of the webinar, an introduction to near-infrared spectroscopy, talking a little bit about what it is and how we use it clinically. I'd like to now take you into the AZH clinic, and let's meet some patients and my staff, and hopefully you get a much better feel for how we can use this clinically. All right, welcome to the AZH clinic. On this side of the house we have our wound care center. We're going to go over to the vascular side today. Come with me. Here's the vascular center. I'm going to introduce you to my partner, Dr. Awais Siddiqui. Dr. Siddiqui is an interventional radiologist. Awais, we're doing a little webinar talking about Kent technology. I understand you just did a procedure.
So yeah, we took the patient. She had significant superficial femoral arterial stenosis. In fact, she had developed a blockage just above her stent that was previously placed. So we opened that up, revascularized her leg, and now we'll demonstrate how the perfusion is on the Kent imaging.
We've been using the Kent looking pre and post procedure.
We've been using Kent pre and post procedure almost every single time, especially in limb salvage cases, and I believe it's an excellent example of a great tool available to us in our center.
We also use it obviously in the wound care side, but let's show you how we use this image in actual real life. Wait, well, let's show the patients here. So this is the young lady that Dr. Siddiqui just did his procedure on. This is our lead technician on the Kent camera, Jonathan. John, you want to walk us through an imaging example here, just demonstrate, and tell our folks in the audience how you're doing this.
So, first step in imaging a patient is to pull up the actual patient. You let the camera warm up. You get a calibration setting, which is simply taking a picture on a calibration plate. And then when ready, you take a picture of the actual area you want to image. Those two laser dots in the center, you can see them getting closer together as I move the camera closer. What that means is you are in the range of field of the actual camera. So you take the picture by pressing one of the buttons. That flash.
So the camera then generates a digital image like we're seeing here.
And that is the STO2 image. You can filter in between color and the STO2 image. You can plot points around the wound bed.
And so, Wace, prior to your procedure, we did have more blue and green around the wound, and now she's got more, obviously, evidence of oxygenation. What are your thoughts on the oxygenation suggesting increased perfusion? Do you think that correlates well?
I think it correlates really, really well. In fact, in most of our Kent patients, when there's demonstration of increased oxygenation post-procedure, we seem to believe that it demonstrates earlier wound healing and is a direct example of revascularization in these types of folks who otherwise, even though you may have revascularized them, but the target lesion may not have been revascularized appropriately. So direct correlation between Kent and revascularization truly helps our patients in this regard.
And certainly from a wound care standpoint, we follow these patients closely. So I hope you've enjoyed this little simple tour and demonstration of the Kent technology. We had the luck and opportunity to show you both how we use it in procedures, vascular procedures, as well as in wound care. You can see it's point of care, it's at the bedside, it's very quick. You can get these images on the fly and make decisions from a clinical standpoint. So I hope you've enjoyed this. We're going to transition now to the Q&A session. Maybe Dr. Siddiqui will be able to join us for that. But I hope you've enjoyed this brief tour of AZH Wound and Vascular Centers. Thank you very much.
Thank you.
Hello, everyone, and thanks for joining us. I am really honored to participate in this webinar and share with you the near-infrared spectroscopy technology and provided via the folks at Kent with the Snapshot device. Hope you've enjoyed the webinar and this overview and this brief clinical tour. We have a few minutes left in this webinar to talk about the technology. So if you do have questions, I'm happy to try to answer those. You can send those questions in via the chat box. While the webinar was going on, we did receive a question, so I want to go ahead and start answering the questions. Judith sent in a question of what is the depth of the device in imaging tissue. Well, Judith, as you saw in many of the photos, we're looking at the dermis and the tissues directly under the dermis. This image is essentially a few millimeters of tissue. We can't image deeper tissues, for example, the deep vessels, if you will, the primary major vessels. This is all going to be the end arterioles, the capillary network, the venous, the small venules, and how those smaller vessels have an impact on the tissue, on the skin, or the wound base. And so we're going to see it fairly superficially. It does have some penetration, but you can't image deeper vessels like the superficial femoral artery, even the anterior tibial artery. So I hope that answers your question. So the question, excuse me, another question comes in, can you annotate images when you're taking them? And yes, part of the process, and I appreciate you pointing it out, that we didn't demonstrate is that you actually input the patient's name, some biographical data. It can be fairly extensive or fairly limited based on how you're going to track these patients. And then the images are taken and attached to that patient name. When you want to re-image that patient, you can search the database, bring that patient's folder up, if you will, and all of the images will be deposited in that folder that's attached to that patient. And we do that on all the patients we image. It really helps in looking back historically and what those tissue images showed as far as oxygenation and tissue perfusion. And again, I mentioned in the webinar, we do use it prospectively, so we do look at the prior images and where that patient is when we're reevaluating them. Okay, hopefully those provided some answers. Does anybody else has questions? I don't see anything here. Sam, my assistant is showing me questions. Okay, here's another one. Does the tissue temperature affect the readings? And do you practice patient warming of the extremity part of the image? That's a great question. I'm not sure who sent that in, but that's a really great question. I will tell you this, that yes, certainly temperature influences tissue perfusion in general. We know that those patients that are exposed to cold environments will have some vasoconstriction, whereas if they're in a warm, hot environment, they're going to get that vasodilation, and that will influence your images. The discrepancy between the tissue temperature and the output, if you will, the photograph in this instance, compared to prior outputs, for example, transcutaneous oximetry, we don't see as severe a swing in oxygenation values as we did with TCOM. So that was pretty substantial, and a small amount of temperature cooling or heating could make a difference there. We don't see that as drastically in the Kent images. The only time we really do practice tissue warming or try to stabilize the tissue is if the patient has been in a prolonged vascular procedure. As you know, those interventional rooms are cooled for the equipment and for the operators, and patients can be chilled after that procedure. And we will do warming of the extremity as well as warming of the patient. These patients do have heated blankets placed on them, and we will do that for a period of time before we image them. So there is a small influence on tissue temperatures on the results and the output of the device, but again, not to the extent that we used to see those with transcutaneous oximetry. Another question. This is can you compare results of skin perfusion pressure to the snapshot? You certainly can, and we do. We have compared these devices. As you know, skin perfusion pressures are typically focal. You get an electrode placed on an area of tissue, and you're monitoring that single site. This device provides the benefit of, again, as I referenced earlier, providing an image of the entire foot, entire wound, entire extremity in certain instances. And so we get a better idea of the perfusion globally, if you will, to the wound site, to the digit, to the foot, versus a skin perfusion pressure, which is a very focal measure. Skin perfusion pressure has been correlated with transcutaneous oximetry, and the values that you get on that focal site will correlate well with what we see in Kent. But again, the amount of information that's gained by the use of near-infrared spectroscopy is significantly better, larger, more comprehensive than what you'd get with a skin perfusion lead. Another question. Question is, how does near-infrared spectroscopy compare to molecular light? It's apples and oranges. Molecular light has no ability to image oxygenation of the tissues. As you know, that device has been designed to image fluorescence of bacteria, and you get no input at all or no feedback from that device looking at oxygenation, hemoglobin saturation values at all. So they're really two different devices. And we have done some comparison with molecular light with the Kent image and looking at serial images in some of the procedures, for example, debridement. We know with the Kent camera, we will get improvement in the perfusion of wounds and peri-wound tissues following debridements. And we'll also see changes in the molecular light imaging, the bacterial fluorescent imaging. But again, they don't, it's not a substitution one for one. These are not equivalent devices, and they're really in two different areas of imaging. Question is, what would a hematoma look like, and is that vascularized? Well, it would sort of depend on whether it's an open hematoma or closed hematoma. If you have a closed hematoma with dermis over it, you're going to see some perfusion, if you will, oxygenation of the dermis over that hematoma, unless it's necrotic. Necrotic tissue is going to present with very low oxygenation values. If you do have an intact viable dermis over that hematoma, you will have some evidence of perfusion. Depending on how tense that hematoma is, I think the perfusion of that overlying dermis is going to be different. A very large, intense hematoma will certainly compromise that overlying dermal tissue, and that would be reflected on decreased oxygenation values. That is the mechanism of injury, if you will, to the dermis that causes tissue loss and death, is decreased perfusion and oxygenation of the tissue that can be caused by the hematoma. So depending on the severity, the size, the extent of the hematoma, you're going to see changes in the overlying dermis. If it is an open hematoma that you are looking at imaging, it has no overlying dermis, that hematoma obviously is not going to have any significant degree of oxygen carrying capacity, so you'd expect those values to be very, very low. We have a couple questions related to reimbursement. Obviously, with any technologies that we work with, reimbursement is certainly an important issue, and I am not an expert in that area. Fortunately, I do have an expert that's done a lot of work in this area with near-infrared spectroscopy. I'd actually like to try this. I don't know that it's going to work, but I'd like to invite Moira to join us on the call. We're going to try to bring her on so she can give some information to all of you about the reimbursement status of this technology as it currently exists. So let's try to reach out to Moira and see if we can get her on.
I am on.
Oh, hello, Moira. How are you?
Hi, I'm great. How are you?
Great.
That was a wonderful presentation. Thank you so much.
Enjoyed it. Thanks for joining us. We do have a couple questions that have come in regarding reimbursement. Could you just sort of give us a state of the union and update as to where we are right now on reimbursement and where we're going?
Absolutely. So on July 1st, Kent Imaging's T codes, which are CPT codes that are assigned for temporary use for evaluation, was assigned an APC grouper code of 5732, which essentially means we get paid, outpatient hospitals get paid, and although it's not as wonderful as we hoped, we certainly are looking at improving that reimbursement ongoing. And then it was also approved for physician offices and professional billing for the image acquisition and report interpretation for those clinics like yours that are freestanding. And then if there are providers that are working specifically in a wound care center, in a hospital where they don't own the device and the hospital does, they can bill for the interpretation alone. And that is going to be on a case-by-case basis per MAC. So all of that information is on the Kent Imaging website, and you can go to kentimaging.com and go to the resources section, and there's a whole section on reimbursement that gives all the codes and their status indicators and suggested documentation, and anyone can reach out to me via the website as well. So.
Great, Moira. Thank you for that. And I really appreciate you offering to be available to anyone that's working with the device, anyone in the audience that does have specific questions related to reimbursement. That's very gracious of you to make yourself available. Do you want to give an email, Moira?
Sure. It's reimbursement@kentimaging.com.
That's your middle name, right? Reimbursement?
It feels like it for sure.
Yeah, I'm sure it does. Well, good. Any other questions out there? Yes, we have more questions coming up, I'm told. Let's see here. Okay, this question comes in from Alan LaRose. Thanks for joining us, Alan. Is there a preferred shockwave treatment that you would suggest, i.e. focused versus non-focused? Alan, are you setting me up here? So I'm not going to take a stand right now on a technology. I certainly have my feelings. I've worked with a number of these devices. I think there are positives and negatives to the technologies that are out there, and they can certainly be compared. And maybe you can reach out to me, Alan, offline, and we can talk about that. That's really not the focus of this webinar, but I'm happy to share my clinical observations with you directly. I will say this, that we have noted that shockwave has a significant impact on tissue, and that's evidenced by near-infrared spectroscopy, and that is reflective of the clinical outcomes we've seen with shockwave. I am a strong advocate of shockwave treatment. We use it on a daily basis here in this clinic, and I think it really is going to be a technology that we'll see utilized much more broadly in multiple areas of clinical practice, but certainly in the wound care clinic. So thanks for that question, Alan. Another question is coming in from Michael Veneri. I hope I said that right. Thanks, Michael. What is the cost of the Kent camera, and where can one be purchased? Well, I've got a couple cameras in my office, and I'd be happy to sell you them. No, I'm just kidding. You would need to contact the company, and again, I have been working with them for the past couple of years on a research basis, so I'm not really able to comment on the particulars related to those financial arrangements, but you can purchase the device, and what I would suggest is that you reach out to Kent directly, email them through the website, and they'd be more than happy to talk with you about that. I will tell you that the Kent company has been very gracious in allowing a trial period of the device, and we have gone through that where you use the device for a period of time, kind of kick the tires type of deal, and then make a decision on acquisition and purchase. The changes in reimbursement certainly make acquisition of a device more favorable now than it has been in the past, and I think that is going to get even better. But we really need to look forward to the future of where we're going from a reimbursement standpoint in wound care, and looking at, if you will, a change from the fee-for-service model, which we currently have, to one of a capitated or a risk-sharing type of model. We are moving in that direction very quickly, and I think a device like this makes sense, and a lot more sense, in a setting where we're trying to predict outcomes and determine whether or not this patient is healable and to what degree they're healable. Incorporating technology into a risk-shared type of reimbursement strategy, I think, is going to be very important and critical moving forward. So I would, again, for more specifics on the pricing and how you would acquire a device, I would point you back to the Kent company and Kent folks, who, again, I'd like to reach out and say thank you for sponsoring this webinar and this educational opportunity. It's been my pleasure to be on this webinar and to work with you on a research and sort of move forward basis. And we have another question, and this one is from Frederick Dreesen. Thanks for joining us, Fred. How about ALFs and skilled nursing facilities? The device is portable. It can be taken anywhere. It can be taken in the home setting. We've done that. You can take it into the subacute facility. We've done that. Certainly throughout the hospital, it can be carried on. So it's from a portability standpoint, from a usability standpoint, there really is no limitation on where this device can be utilized. The reimbursement, I would defer to Moira as far as what the reimbursement of those different settings would be. I don't know that, but obviously, taking the care of wound care to the patient in these skilled nursing facilities has really become sort of the current trend. Rather than transporting these elderly patients across town to the wound center, doing on-site visits has become very much in vogue, and I think a better way of doing business. Taking the camera along and shooting an image is not difficult, and it's readily doable. So I can tell you, yes, from a operational standpoint, from a reimbursement standpoint, again, I would ask you to get a hold of Moira and ask her those questions. What? One more? Yeah, we can do one more. My trusty executive is right next to me, Sam. She's in the background, and Sam really deserves a thank you. She put a lot of work into this webinar, and appreciate all your help in coordinating, Sam. Another question from Judith. I think she asked a question earlier, Judith Nolan. Great questions, Judith. Are the images automatically uploaded to the cloud, or is that a manual process? So they're automatically stored, and right now, Judith, they're stored on the device, on the local device. And Kent, I know, is working in a number of different areas to incorporate these images potentially into the EMRs, potentially to a cloud-based server. They're looking at some special analytics and some artificial intelligence type protocols where these images could be analyzed and that feedback provided to the providers. So there's a number of things that are being looked at right now as far as where these images will reside and backed up. And but right now the current camera allows for storage on the local device. And the cloud is probably going to be available next week. No, it'll be very soon. The rollout for that cloud-based application. We have been suggesting that they move forward with that for quite a while now, and so a lot of work and effort has been put into that, and an emphasis on moving towards interfaces between EMRs and cloud-based systems is clearly been a priority for Kent. All right, well, I see we're at the top of the hour. Once again, I'd like to thank all of you for taking an hour of your lunch or wherever you are to join us on this webinar. I'd like to thank the sponsors, Kent Imaging, for their assistance in making this a reality and providing this educational opportunity. And I'd certainly like to thank Samantha Bialis and the WebCME crew for all the background work. I'd like to compliment and thank my partner, Wais Siddiqui, for his efforts and contribution to this webinar and his comments, which were very insightful from a vascular standpoint. And finally, I'd like to thank my son and hopefully protege, Jonathan, who has done a lot of work with these images and hopefully will be entering medical school one day. And finally, thank you to Brandon Hoffman, who is currently in medical school. He was an MA here, and he successfully moved from AZH to medical school, and we're really happy for him. So thank you all, and maybe we can do this again in the near future. Have a great weekend.